Hi, we're going to get started with Chapter 11, Nursing Care of Patients with Cancer. As a reminder, this next unit has 4 chapters, chapters 11, 20, 27, and 28, and it is also a 50-point exam. The objectives I'm going to let you read on your own, and remember that the objectives are also on the first page of the chapter, as well as the objectives that are in your course guide. So really important that you can answer those objectives when you are studying for the exam. Cancer pathophysiology. So we're going to talk for a minute about cancer cells and how they differ from normal cells within our body. Cancer cells are different because they are mutations of cellular genes. So we know right now there's over 100 different types of cancer that can affect the human body, and these cancers are caused by mutation of cellular genes. In our working lifetime, we will likely see potentially more different types of cancer arise, but that's what we're aware of at this time. These cells also have abnormal cell growth. So these cells divide much more rapidly. Normal cells are going to divide about 50 to 60 times before the cells themselves die, but cancer cells are going to keep dividing until either their host dies, so the individual that has the cancer dies, or the cancer cells are killed by radiation or chemotherapy or some sort of intervention. Otherwise, they're just going to keep replicating, and they're going to replicate very fast, and they're not the cells that as they replicate aren't going to die. So when you think about how fast those can reproduce from normal cells, it's quite scary. These cells also have no cell division limit. We just talked about that. And they have a lack of contact inhibition. Contact inhibition, these are growth regulating signals in the cells surrounding the environment. So these signals get ignored with cancer cells. In regular cells, the contact inhibition signals kind of help control how fast the growth takes place. So with contact inhibition or lack of contact inhibition, that allows these cancer cells to continue to keep dividing, and when they do that, they start invading surrounding tissue. On Brightspace, there's a cell division video that I typically show in class, and there's no talking during the video, but it really helps illustrate to you how fast and how cancer cells divide, and it kind of piggybacks off of the graphic that's on this slide. Cancer etiology is an important topic to cover. This is something you definitely have experience with in your everyday life, but you will be doing a lot of patient education related to this. So cancer caused by an exposure to a carcinogen, and we know all different kinds of carcinogens if we stop and think about it. Secondhand smoke, the primary individual that smokes, asbestos exposure to different toxic chemicals and materials and all different types of things. In a nutshell, when we are exposed to these different carcinogens, 2 things are going to happen. Initiation is going to happen, and this is this is when the carcinogens cause the genetic structure of the cell DNA to actually alter, okay? Altering that genetic structure of the DNA within the cell. So that happens. And the other thing that happens is promotion. And promotion is when there's repeated exposures to carcinogens. And those repeated exposures cause the cells to mutate. So think of someone that's exposed to secondhand smoke 2 times versus someone that's exposed to secondhand smoke for 10 years, okay? Those the cell response and likeliness for that promotion to occur is going to be much higher for that individual that has a longer, more frequent exposure. Something really important to think about is a healthy immune system can destroy cancer cells. So if we eat a healthy diet, we exercise, it doesn't mean that, that's a do-all end-all. You'll never develop cancer, but it does mean that our immune system can fight off some cancer cells from developing and mutating. A weakened immune system increases the risk of cancer cells not being destroyed. Okay, a weaker immune system. And I know, in some cases, and recently I was reading some articles related to this, that individuals that are obese and carry a lot of extra fat cells around and things like that have a higher risk of developing certain types of cancer. And kind of, just going along with just the overall health of the body and the immune system and those types of things. So obviously that's not a cut and dry phenomenon, but it is something to think about as far as overall health and health promotion for our clients. Cancer risk factors, so things that put us at greater risk. Oncoviruses, these are RNA type viruses, so examples would be like HPV or herpes simplex 2, radiation, chemicals, and think of things such as alcohol, cigarette smoke, any sort of pollution chemicals. Irritants, examples would be things like asbestos, snuff, pipe smoke. Genetics. So we know that certain types of breast cancer have a genetic link or a genetic component. So if that female has a strong family history, it's highly encouraged that he or she, it can occur in males, but that they receive genetic testing to see if they're high risk. And sometimes these individuals will have a mastectomy that's elective just to help decrease the risk of the breast cancer that they know they're very likely to get. Same thing with men, prostate cancer, those types of things. We tend to see a little bit of a genetic component. Diet, so eating a high fat, low fiber diet can increase the risk of colon cancer, and that low fiber diet is going to not make things pass as quickly in the colon, and so the longer those materials sit in there before they're excreted, that's going to increase inflammation and put us at higher risk. Excuse me. Hormones, so women that take estrogen supplements can be at higher risk for breast cancer, uterine cancer, ovarian cancer, cancer of the cervix, or vaginal cancer. And then different immune factors, how our immune system, the strength of it, can put us at greater risk. So normally in class we kind of divide and conquer and talk about these risk factors. When you're reading your chapter, I also want you in this section to look at some of the different cultural considerations. We tend to talk about this in small groups in class, so just make sure that you do good, thorough reading. Cancer classification. 4 classifications we'll discuss here. Carcinomas. When you look at these, other than leukemia, do you notice the words all end in the OMA-S? OMA. So the OMA, the OMAs, and you can add the S on there as well. But these, when we're looking at the words, can kind of jump out to us and signify that it's a type of cancer. Okay, so carcinomas happen on the skin, they happen in the GI tract, they happen in the lungs. These are the most common types of cancer. Sarcomas happen in connective tissue. These can include things like fat tissue, sheaths, those myelin sheaths that serve as connective tissue within our nerves, cartilage, muscle, or bone. Leukemia is cancer that occurs related to the white blood cells. And lymphoma is cancer that occurs in the lymphatic system, lymph nodes, or spleen. Cancers are identified by 4 different things, and you'll want to write this kind of in the side notes here. The first thing they're identified by is the tissue that's affected. The next thing that they're identified by is the speed of cell growth. The third is the cell's appearance. And the fourth is the location. In your book, table 11.2 is helpful to expand upon this a little bit more. Cancer metastasis is something that you've probably heard about already, but maybe didn't fully understand. But this is something that we see a lot in our nursing practice when we talk about someone who has cancer that's metastasized. And what that means for the individual as far as if they're able to respond to treatment and how it might affect their overall functioning. So when cancer metastasizes, it moves from the area that it started at to another area within the body. So when this happens, there's 3 steps that take place. That cancer invades the blood or lymph vessels. That allows it to travel. It moves by mechanical means to another area of the body, and it lodges and grows in a new location. I find this illustration kind of helpful. I like visual aids to help. So let's say somebody has lung cancer. They have a lung carcinoma. That lung cancer tissues or cells within that get into the lymph system or through the vascular system, and they travel to another area of the body and decide to lodge and invade. So in this example, they travel and invade the liver. So this person would have lung cancer that has metastasized to the liver. We see a lot in situations where someone has, maybe they have, it can travel about anywhere, but let's say somebody has cancer somewhere in their body. We'll say they have cancer in their lungs and it metastasizes to their brain. We tend to see a lot of changes as far as mood, cognition, risk of seizures, all different types of things that will give us kind of signs that that may have happened before a scan even takes place. So the scary thing is when someone goes in to have a scan to see if their cancer is better or worse, that's when they'll identify if the cancer has metastasized. And in some situations, someone has cancer, it's not caught early, and it's already metastasized to other areas of the body. And we know that that puts that individual at a decreased risk of chance of beating that cancer and survival, depending on what organ systems are affected. Incidence of cancer and most common incidents, so incidents where it occurs, their figure 11.8 in your book is helpful related to this. So as far as men and women, the incidence is different. The most common type of cancer for adults is skin cancer. So the most common type is skin cancer. But skin cancer is also one of the most preventable types of cancer. So really encouraging as nurses what our clients can do to help decrease the risk of getting skin cancer. We talk about cancer when you're looking in your book on 11.8. I want you to look at the cancers that put individuals at highest mortality rate. Okay, so most common cancers versus most common cancers that are going to cause death. So study that a little bit as well when you're looking at these, because you need to kind of be familiar with who you're taking care of, what kind of cancer they have. Is that more severe or at risk for being fatal versus another type of cancer? The highest mortality rate cancer for both men and women is lung cancer. So we know when our clients develop lung cancer, that is not a good prognosis. Okay. Not good high mortality rate. Cancer early detection and prevention. So making sure our clients get regular physical exams. Females get pap smears, and that regulation has changed a little bit on how frequent those are done, but really important. Cancer screening, so whether that's skin cancer, prostate cancer, cancer of the cervix, any breast cancer, genetic testing, healthy lifestyles, and protectant foods. So foods that are high in folate, which would be foods that have that are like dark green leafy vegetables, beans, folate enriched pastas, breads, anything that has that folic acid in it can help us decrease scar risk. Also lots of fruits and vegetables, and then vaccines if they're available, for example, in women, like the Gardasil vaccine, and in men, the Gardasil vaccine to prevent against HPV, which can cause cervical cancer. So we need to think about, though, why might our clients not come in to get screened? So just because they have access doesn't mean they're going to come. And that may be because they have the fear of just coming to the hospital or clinic. Maybe they had a family member that had a bad experience or a bad prognosis, and because of that, they're not coming in. They may fear, not understand the testing procedures. They may think they're painful. They may just have a lack of overall knowledge about why these detections and screenings are important. So as nurses, we really need to develop a trusting relationship with these clients. And we also need to realize that when these clients call to schedule their appointment, they may have waited 6 months to make that phone call. So if we're not on task and polite and understanding, that could discourage them to not call us back for another 2 years. So we need to think about that and what could be going on at home. Or maybe they had a friend or family member that just died of cancer, and that's what made them want to make the phone call. So we need to think, about all the different things that could be going on. All right. Diagnosis of cancer. Biopsy is the most accurate way to identify cancer. So until there's a biopsy done, it's not really confirmed. So let's say that someone has a CT or X-ray or some sort of imaging done, and there's a suspected area that looks suspicious of cancer. That area has to be biopsied in order for it to be completely confirmed. So that's really important. Radiology procedures are done, X-ray, CT scans. The scary thing is, as nurses, a lot of times we find cancer on someone that came into the hospital for a completely different reason. So let's say they came in because they had shortness of breath and they thought they had pneumonia, and it's discovered on their X-ray or CT scan that it looks suspicious of cancer. So you're going to have to deal with a lot of those first-time conversations, diagnoses with your patients once the provider has given them that news. So that's a difficult thing, but really being supportive. Nuclear imaging or PET scans, position emission tomography is what PET stands for. These is when radioactive tracers can be used to help reveal how tissues or organs are functioning. Ultrasound is used, MRI scans, magnetic resonance imaging is used, endoscopes, which we talked about in nursing concepts. Think of those, especially if it's anywhere in the GI tract, laboratory tests, or cytological studies. For somebody that has cancer, and this is not absolutely something that will 100% of the time happen, because other things can come into play. But a good rule of thumb to think about is we know that white counts tend to run normal for people, usually 8,000. And remember, it's times 10 to the third. So sometimes I'll say 8, but it really means 8,000. 8, anywhere up to 12, it's pretty normal. Somebody that has cancer, especially undiagnosed cancer, they may come in and their white count's like 3 or 2, meaning 3,000, 2,000. And that is because of how the cancer is invading their body and their ability of their white cells to fight. But that's always something that I want you to not react to or say anything to your patient, but I want you in the back of your mind to think, do they have a cancer diagnosis, or is there something going on that hasn't been discovered yet? So just a little side note, and again, there are exceptions to that, but overall, kind of be thinking a little bit. Remember that a cancer diagnosis is a very frightening experience, obviously, for the individual. And patients will often mask their symptoms related to this fear. So somebody may have been having diarrhea, GI upset, coughing up blood, all different types of things for a while at home, and they were scared that it could be cancer, and being scared caused them not to come to the hospital or the clinic because they thought, well, maybe it'll stop on its own, those types of things. Staging of cancer, we don't get into this a lot in detail because depending on where you're working, you may have more exposure to this, but make sure when you're reading, there's table 11.4 does a nice job talking about staging of cancer. I also have a video link in Brightspace that talks about staging related to melanoma. When we talk about staging, we talk about TNM, tumor node metastasis. So T meaning that the cancer is still in just a enclosed tumor form that hasn't traveled anywhere else. Node means that that cancer has now spread into the lymph system or a lymph node, and metastasis we talked about meaning it's gone to another organ system in the body. Okay, so let's think of breast cancer. Tumor staging would mean that the breast cancer is still contained to one single tumor within the breast tissue. Node would mean that that cancer is now not only in that tumor, but it's spread into the lymphatic system around the breast tissue. And metastasis could be that that breast cancer now traveled to the bladder, and patient now has breast cancer and bladder cancer. Okay. Within that, stages 1, 2, 3, and 4 come into play as well. So take a look at that chart. I think it's easier to visualize that than to verbally explain that on here. It's not going to make as much sense unless you have it in front of you. Treatment for cancer, so surgery. If it's breast cancer and it's a tumor and it's contained to the breast tissue, then that breast may be removed. If it's prostate cancer and it's contained within the prostate may be removed. Radiation and chemotherapy. And in this course, we don't get into a lot of the details related to these, but realize that there's complications that can arise. So someone that's having chemotherapy, that medication is not only killing the cancer cells, but it's killing the healthy cells too. So we know that these patients are very immunocompromised. Right now, with everything going on, these patients are at very high risk for contracting this COVID-19. The other thing to think about, and I've taken care of patients that have had radiation, especially in the chest, and that radiation can cause like burning of the esophagus if it's not done, if complications arise. So just know that it's very complex. Nurses need special training before they can administer chemotherapy. Side effects of radiation: fatigue, makes people really tired, nausea, vomiting, anorexia, mucositis, which is inflammation and ulceration of the mucous membranes of the digestive tract. So this could be not only in the mouth, but this could be any mucous membranes, present back of the throat, anything like that. Xerostomia is dry mouth, and we know that dry mouth puts our clients at greater risk for developing bacterial infections. Skin reactions, bone marrow depression. Radiation safety. So if you're working with someone that is receiving radiation treatment, there's three primary factors that are important to protect us as healthcare personnel, and also to protect patients, friends, and family. So before we talk about these three things, I'm just going to talk about two different types of radiation. In your book, Figure 11.12 talks about some of this radiation safety. So there's two different types of radiation. There's external radiation. This is given by a trained professional in healthcare. Patients don't emit radioactive material, and they don't require any safety precautions before or after treatment. Okay, external radiation. So basically there's an external machine that's used to give the patient the radiation treatment, and then that patient is not nearly as high of risk to healthcare personnel, friends, or family as somebody that receives internal radiation. Internal radiation is when the radioactive material is implanted into the body tissue, either by being administered orally or intravenously. Okay, so internal radiation. Sometimes after individuals have like their thyroid taken out or things like that, they have to do certain precautions related to internal types of radiation that they receive. So really important that you understand if it's external or internal, what that means as far as your role. So three factors to think about that are going to help us be more safe around patients that have had radiation, especially that internal radiation, is time. So our time spent administering care, we want to minimize. So we want to cluster and do what we need to do and not spend extra time in the room. Distance, so the amount of space between the radioisotope and the nurse, the greater the distance, the more protection that we have. Meaning that if I need to go to my patient's room to ask them a question, I'm going to try to do what I can, not right next to them at the bedside. Shielding, use of a barrier such as a lead apron, and that shielding is going to help protect us from radiation. Chemotherapy. Chemical therapy that uses cytotoxic drugs to treat cancer. Chemotherapy has systemic effects, so it works throughout the body unless it's used topically. So for example, think of, chemotherapy as far as IV solution. It's going to run throughout the whole vascular system unless it would be used in a topical form. Routes of administration can be oral, intramuscular, intravenous, and topical. Some chemotherapy drugs are vesicant drugs, meaning that if they leak outside of a vein, they can cause blistering and tissue injury that may lead to tissue necrosis. And that's what's illustrated here on the visual picture on your slide. So there's drugs that aren't chemotherapy drugs that can also do this. And really the big take-home message here is making sure that you're checking your patient's IV sites, ports, PICC lines, whatever they have at the minimum of every 2 hours that you're required, but really should be checked more often when these types of medications are infusing. So that darkened area that we see on this patient, they had a port that had leaking that happened, and it was a vesicant chemotherapy drug, so it caused that tissue around to have necrosis or die. Usually this happens mostly when the drugs are given intravenously, and sometimes they'll get some blistering as well, especially if it's infiltrated IV site. Side effects of chemotherapy: bone marrow depression. So these clients can have leukopenia, thrombocytopenia, or anemia. Leukopenia is low white blood cell counts. It can also be called neutropenia. Thrombocytopenia is reduction in platelets or thrombocytes. This is going to put these clients at increased risk of bleeding and bruising and can require them to potentially have a platelet transfusion. Remember that normal platelets are about 150,000 to 400,000, so something to keep in mind. Anemia can also happen. This is related to reduction in red blood cells and may require a blood transfusion. Nausea, vomiting, diarrhea, stomatitis, which is sores or inflammation in the mouth. That's what's illustrated here in the graphic. And realize if you don't do a good assessment, if you don't look in the mouth, you're not going to catch these types of things. So our client with these stomatitis type of abnormalities in the mouth might not want to eat, they might not want to drink, and we just think, oh, they just don't want to cooperate. No, their mouth is super painful. So you have to take a look. Alopecia, which is sudden loss of hair leading to baldness. Reproductive alterations and neurotoxicity. There's a mnemonic called BITES that can be used when assessing patients with side effects of chemotherapy and radiation. The B stands for bleeding because they have low platelets. The I stands for infection, suggesting low white blood cell counts. The T stands for tiredness because they could be anemic. The E stands for emesis, and they are at risk for altered nutrition and fluid and electrolyte imbalance. And the S stands for skin changes, maybe evidence of radiation reactions or skin breakdown. So if that helps you kind of remember some of the side effects, that's an acronym that can be used. Nursing diagnoses related to cancer, so ineffective coping, acute or chronic pain, risk for infection. Remember, their white counts are going to be low, so their fighting power is greatly reduced, so they have a lot higher risk of infection. A lot of times these individuals are going to be in what's called protective or reverse isolation so that we don't bring anything in and expose them to whatever cold or flu that we might have. Ineffective protection, imbalanced nutrition. Remember, we said they're nauseated, could be vomiting, they could have those stomatitis sores in their mouth, deficient self-care, grieving, risk for ineffective role performance. So maybe the individual that gets cancer is the main person in the household that brings home an income, or maybe the person that gets cancer is the main person in the household that does all the cleaning, laundry, running kids to activities. So we need to think about all of those things in helping our patients. Social isolation, especially those patients that have that internal radiation implanted. We're not going to let people really be around them. Ineffective sexuality pattern, disturbed body image. There is an excellent video that I play during class that I really want you to take the time to watch because it kind of makes all of these words actually apply to a person instead of just words on a page. So it's a lung cancer story about a lady named Missy. It's a cancer survivor video, and it's excellent. So take the time to watch that. All right, so that finishes up chapter 11 related to cancer. I do have a worksheet that I am going to post, and I'll give you more direction in your announcements, but there is a cancer review question worksheet that I will post. So please let me know if you have questions. Thank you.